Hello everyone, my name is Hina Patel and I'm a member of clinical team here at Aegis from Nashville, Tennessee. Today I will be reviewing opioid results interpretation with you. Objective for today's discussion include review opioids and opioid metabolism, discuss unexpected results due to major and minor metabolism pathway, understand opioid detection in urine versus oral fluid drug testing, and then we'll review sample reports and where to seek out additional clinical support. I would like to first review the types of opioids that are currently available on the market. Please keep in mind that the parent term opioid encompasses both naturally occurring opiates, semi-synthetic, and fully synthetic drugs. The naturally occurring opiates include morphine and codeine. These substances are naturally derived from opium poppy plant. Hydrocodone, oxycodone, hydromorphone, and oxymorphone are considered semisynthetic as they are derived from naturally occurring opiates. Methadone, fentanyl, meperidine, liverphenol, buprenorphine, and tramadol are fully synthetic opioids. Many metabolites of opioids are commercially available prescription drugs, which can cause a bit of confusion when interpreting a patient's urine drug test. Next few slides will highlight the major, minor, and norm metabolites of opioids. So during the natural pharmacokinetic patterns of drugs, which are absorbed, distributed, metabolized, and excreted, metabolism of drugs play a major role in excretion as well as the clinical effect of medications that a patient is taking. Opioids specifically undergo extensive phase 1 and phase 2 metabolism. Phase 1 metabolism occurs primarily in the liver cytochrome P450 enzymes, specifically CYP3A4 and CYP2D6. CYP3A4 metabolism is subject to induction and inhibition by many drug-drug and drug-food interactions, potentially altering opioid metabolites, norm metabolites concentrations. Drugs that inhibit or induce CYP3A4 route of metabolism can modify the effect of opioids, which can lead to either a decrease in analgesic effects or adverse drug effects such as sedation, respiratory depression, and or death. 2D6 cannot be induced. It is subject to inhibition by a host of medications and may also become saturated. 2D6 also inhibits a tremendous amount of genetic variability. So the clinical significance of CYP2D6 inhibition is variable and highly dependent on its role in metabolism of opioid. CYP2D6 inhibition can lead to an increase in active parent drug or a decrease in active metabolite, leading to either a decrease in analgesic effects or adverse drug effects such as sedation, respiratory depression, and or death. For example, codeine. Codeine is a prodrug and needs to be activated by 2D6. So codeine is metabolized to morphine via 2D6, leading to an analgesic effect. So inhibition, or someone who's a poor metabolizer of 2D6, can lead to decrease in analgesic effect. In phase 2, metabolism takes place by glucuronidation, which causes substance to become more water-soluble and allows for excretion from body. Two major metabolites of codeine are norcodeine via CYP3A4 and morphine via 2D6 metabolism. Hydrocodone's major metabolites are hydromorphone via 2D6 and norhydrocodone via CYP3A4 and also dihydrocodeine. Oxycodone's major metabolites include oxymorphone, which is a product of 2D6 metabolism, and noroxycodone, which is a product of CYP3A4 metabolism. Morphine, hydromorphone, oxymorphone are pharmaceutically active drugs pharmaceutically active and commercially available prescription drugs as well, which are a product of CYP2D6 metabolism of codeine, hydrocodone, and oxycodone, respectively. A minor metabolite of codeine is hydrocodone, and morphine's minor metabolite is hydromorphone. Neurometabolites of opioids are such as norcodeine, norhydrocodone, and noroxycodone are unique biomarkers formed after the use of corresponding drugs. For example, norcodeine after codeine ingestion and are product of CYP3A4 metabolism. Although this metabolite possesses weak opioid activity, they are not likely to contribute to overall analgesic effect. Let's look at metabolism of synthetic opioids. The metabolites of synthetic opioids can be seen on this slide. Of note, synthetic drugs can have unique metabolites, but are typically normetabolites. So for example, buprenorphine metabolizes to norbuprenorphine, and fentanyl metabolizes to norfentanyl. You can see some other drugs on the list as well. The next few slides will include a few Aegis urine sample reports demonstrating positive results for prescribed opioids. This specific example is for hydrocodone on a definitive testing via mass spectrometry. I would like you to focus your attention more on the style of reporting and the presence of biomarkers and less on the concentration present, as it will vary significantly from patient to patient due to pharmacokinetics and pharmacogenetic variability. So in this sample, you see the presence of parent hydrocodone and the metabolites, norhydrocodone, hydromorphone, and dihydrocodeine. Hydromorphone and dihydrocodeine are also prescription drugs. This slide demonstrates urine positive result for prescribed oxycodone. This sample, you see the presence of parent oxycodone and the metabolites noroxycodone and oxymorphone. And oxymorphone is also a prescription drug. So when using definitive testing, which minimizes the risk of false positive, but you may see unexpected positive results from minor metabolism of opioids, the presence and concentration of minor metabolites for hydrocodone as a metabolite of codeine and hydromorphone as a metabolite of morphine are relatively low. Let's look at a few examples. This report shows a codeine positive result with a low concentration of hydrocodone, which is a metabolite, a minor metabolite of codeine, along with morphine and norhydrocodone and norcodeine. Morphine is expected major metabolite of codeine. Next, this report shows a morphine positive result with a very low concentration of hydromorphone as a minor metabolite of morphine. So when you see a no metabolite comment on our report, is it possible for you to see a parent drug without metabolites? It is possible to observe parent drug presence in a urine in the absence of metabolites. This may be increased in patients with impaired metabolism due to genetics or drug-food interactions. Detecting parent drug-only compound may suggest recent oral drug ingestion, though the drug concentrations in these cases should typically be low. Now let's talk about opioid detection in urine versus oral. In urine results, you see drugs and metabolites typically present in high concentration with longer period detection. So the period detection for most opioids is up to 5 days in urine, except for few drugs such as buprenorphine is seen up to 7 days and methadone is up to 10 days. In oral fluid results, drug metabolites typically present in lower concentration than the parent drug, and the period detection of drugs in oral fluid is typically up to 48 hours. So in general, the detection period will vary significantly from patient to patient depending on medication dose, dosing frequency, drug half-life, and pharmacokinetic parameters of the patient. Also, it is important to note that the drug concentration in both urine and oral fluid does not correlate with the amount of drug ingested by patient. This concludes my presentation. Thank you for your attention. If you have any questions regarding Aegis lab reports, please do not hesitate to reach out to us. We would love to speak to you. Thank you for your time.